Hello.
Good morning, everybody, and welcome to the fifth in a series of Positive Approach to Care webinars. My name is Diane Terada, and I'm with Catholic Charities Hawaii. This webinar is provided through the Hawaii Circle of Care for Dementia, a Catholic Charities Hawaii project funded through a grant from the Administration on Community Living's Alzheimer's Disease Program Initiatives. I want to thank our partner, Halikuike, for hosting this on their Zoom platform. You'll notice there's a poll up, so please take a moment to answer the questions in the poll. There will also be a post poll that we will need your assistance to complete as well. Hawaii Circle of Care for Dementia is part of the senior services programs offered by Catholic Charities Hawaii. So if you've not had a chance yet, please go ahead and visit our senior services pages on our website, catholiccharitieshawaii.org, or you can call our senior services helpline at 527-4777. And now I'd like to introduce Jody Michon, project coordinator, who is going to introduce our great speaker today. Jody?
Thank you so much, Diane. Yes, the goal of this grant that Diane is mentioning is to support persons living with memory loss and their caregivers by providing effective dementia-capable programs, services, and resources to help them remain independent and safe in their communities. It includes dementia trainings like this for professionals and unpaid family, friend, or neighbor caregivers. And we're doing all of them virtually right now. As you know, this is the way of life for all of us. But we really appreciate being able to invite everybody from all over the state. So welcome this morning. As you've seen in the confirmation emails for your registration, we're having a special add-on webinar for this series next week, Tuesday, November 10th, same time, 10 a.m. in the morning, to follow up on Dorothy's session today. It will be specifically on advanced care planning and dementia, given by Hope Young of Kokua Mau, which is a movement to improve care, and Dorothy. Kokua Mau has a long history of improving care, palliative care, and other wonderful things like legislation for polls and advanced directives. So Hope is really an expert on this topic. So we look forward to that. You can register with me directly for that by email, phone, or chat today. All of it is being recorded, including next week and today. Many of you have already done that to register with me for next week. So thank you very much. Our final session for this series will be on November 12th next week on dining with dementia. Now to introduce Dorothy. Dorothy Colby is a dementia care specialist and a certified TIPA Snow positive approach to dementia care trainer and national support mentor. She is the Director of Community Engagement for Halikuike Memory Care Homes in Nu'uanu, Bayside, and Pali locations. Homes devoted to excellence and current international best practices in dementia care and environment. Dorothy has more than 20 years of professional and personal experience in caring for people living with dementia. Her positive approach to care workshops provide essential information for families and professional care partners on how to have a positive and meaningful relationship with loved ones with Alzheimer's disease and other forms of dementia throughout their journey. Her trainings focus on understanding what's happening to the brain so that we can empathize, adjust our approach and expectations, and be able to connect and support those who are living with dementia. With that, I'll turn it over to Dorothy. Thanks so much for being here, Dorothy.
Thank you. Thank you, Jody. Thank you, Diane, for making this all possible and for the wonderful introduction. Before we get started into the meat of today, I wanted to just do a few Zoom housekeeping items, just to make sure everybody knows you're all on mute. You're all muted and in listen-only mode, but we do want to hear from you. So please use the Q&A feature to submit any questions anytime through this webinar. There is if you have any technical issues, you can use the chat. You can chat directly to us panelists. But if you have any questions regarding the content, please use the Q&A. This, as Jody said, this webinar is being recorded, and you'll get a link to that afterwards. Also, a link to the PowerPoint slides for today as well to download. There are no CEs, continuing education credits, for today's event, but you will receive a link to be able to download a printable certificate of completions for in-service hours, for hour and a half for this one. And at the very end, when you log off of this webinar, a screen will pop up and ask you to fill out a survey. We really want to hear from you, and we want to improve every single time. And so again, this is also part of the grant, the information we get from this pre-test and post-test, and this survey at the end helps make it possible for us to do more education events like this. So thank you so much for all of that. I am going to take down this poll. Actually, I'll leave it up for a little bit more. I'll leave it up for a little bit more while we just go through what we're going to do today, and then I'll take it down to give people who are just logging on a chance to take the pre-test. So today's topic, end of life care, and is one that can be very difficult to talk about end of life planning and the changes with dementia. But it was such an important conversation. I really commend all of you for signing up for this and taking the time to dig into this such important topic, and one that is especially close to my heart with my experience with people living with dementia and the full journey of it, and making all of it as good a quality of life as possible. So today we're going to be looking at what is different about for someone who's living with dementia towards the end of life as opposed to people who aren't living with dementia. We're going to look at the different approaches to care to consider. What are the different options? What works at one stage and might not work so well at others? We're going to think about and examine letting go versus giving up on someone. So as we start to see that they're reaching the end of their life, what are the choices and what can we do to support them? We're going to look at how we're going to know that we're reaching the end of the journey, of life's journey. We'll dig deep into comfort care and dementia, specifically, that level of care. And then finally, pearls. For some of you who might have been in other webinars, the GEMS model of looking at dementia progression from early, middle, late, or you might be more familiar with numeric systems, level 1 through 5 or 1 through 3. We're going to look at the very end stages of dementia and find the beauty there and the person within. So I'm going to take down this poll here. If you didn't get a chance to take the pretest, it's okay. You'll get a chance at the end again. And so I'm going to just end that one. All right. So I wanted to say for a moment, personally, I've worked at Haliquike since 2005, since the year that it opened. But also personally, I've had a lot of family members who lived with dementia and that I got to be on their full journey with. So my grandmother had Alzheimer's disease and lived with my parents until through the end of her life. And then my father had vascular dementia, and he actually was, his full journey, he ended his life, we worked with St. Francis Hospice, and he was at St. Francis Hospice facility. And then my father-in-law had Parkinson's disease, and his journey ended in a more medical setting, in a skilled nursing setting. So each of them had a unique journey and unique length of time. And so the thing that we want to look at today when we're looking at why is dementia so different, there are so many different kinds of dementia. Like I said, Alzheimer's, vascular, Parkinson's, alcohol related, each unique has a unique effect on the brain, and it causes different kinds of brain damage over time. And it takes it can be such a long journey. So while all dementias, all diseases that cause dementia do cause progressive brain damage and ultimately lead in death, it is a terminal condition. It takes so long that it's sometimes hard to wrap your head around, like this is a terminal thing that someone has. For my grandmother, for example, from the time when I would say her of course, we didn't know it at the time. We thought, oh, it's just normal old age. You get old, you get senile. But her dementia signs really started in the, I would say around 1987 is when I can remember, like, oh, that was a sign that she had dementia. And she didn't pass away until 2001. So hers, of all my family members, it was extraordinarily long time. And so, but each person is unique. So the person that we know and love and are caring for, whether it's our own family member or so if we're professionals and caring for people, the person is changing and changing and changing. And that is hard to adjust to each day when you just feel like you got the hang of it and they're stable. And then something changed, there's a decline or there's some, fall that leads to another decline. It's a rough road. It can be quite a roller coaster that's generally going downhill. A lot of things that we knew and loved about the person seem to be lost in some ways because we start to have trouble. They're here, but I'm having trouble communicating with them, and we're just not able to connect. And I feel like I'm already starting to grieve the loss of someone, and they're still here. And so that's something different than people who are reaching the end of their life without dementia. And it's when one person has dementia, you can put your fingers up if you want to, along with me. Everybody around them has it too, is affected by it too. And then whoever, if you, the closest caregiver, your care partner in this journey, you're changed over this journey too. So that's a big thing that we're so wrapped up in the care and in the moment that we don't realize what kind of things have changed for us. And it's just so different. How it was is not how it is anymore. And sometimes it's hard to get to that point of acceptance. And we were always trying to get back to where it was. If I just did this differently, if I just did that differently, we could go back. And things that used to work don't work anymore. So the approach we used to do, the changes we've made in our lives, it just doesn't seem to be doing it anymore. And so that's something that's very, very different. So the special set of challenges. So when we're going through this journey together, we want to start thinking, I want to start this, even though we're talking about the end of life and we're talking about different kinds, a lot of time on comfort care and palliative care, of course, but I want to take a look at what are all the approaches to care that for you and me and the people living with dementia that we're caring for, that when those things do come up, what are the choices we have and what works for us or might have worked for the person we're caring for earlier on, is that still working anymore? So we're going to take a deep kind of look into that and see what we can notice from our own experiences. So there's these let's see, 1, 2, 3, 4, 5, 6 of them. I'm going to start with health promotion. So these are things that are to help us be the best we can be. So if you think to yourselves, like, what are all the things that your doctor or whoever, medical professional in your life is telling you that you should be doing to improve your physical and mental health. So what's on the screen here are some examples. We get checkups. It says lower the numbers. So what are all those numbers? What are all those numbers that we're all monitoring? Blood pressure, cholesterol, weight, blood sugar. It was all about the numbers. And so we do things, whether it's through exercise or other, changing diet to try and keep that in the healthy range. So we are doing this health promotion and preventative things like vaccinations, flu season, everybody get your flu shot, to help us stay healthy and then become even healthier, right? So these things are also important for people who are living with dementia, but some things, some of the goals of it might be a little different. So we might do preventative things like at Halikuike, making sure all of our residents and our staff as well have our flu shots so that we can lower the risk that way. And we do want to have some kind of activity, physical activity and exercise, but is the goal the same as now when, for example, if I were going to like work with a new exercise program, my goal would be to, really increase my strength or to my cardiovascular level. So for the person that you're caring for, who's in their 80s perhaps or 90s, is the goal of the activity level to build muscle again and things like that? Probably not. It's more of a maintenance thing and not so much the improvement. We're not going to get improvement. And same with the eating. The time to make diet changes for your well-being and future health is now. So when I'm 90 and you want me to change to change my diet and okay, now you can't eat all that ice cream anymore, Dorothy. It's like, well, in the scope of my life, is that really going to make a big difference at this point? So we want to, that's an interesting thing to look at and think about. So the next one that we do is curative. So the goal of this is to fix it. So that whatever we're going to do, something is wrong and we need it fixed. So it might be, I need surgery for something. I need to start taking a certain medication for it, or there's some kind of treatment. But the ultimate goal is an expectation is full recovery. So sometimes that for someone who's living with dementia, there's an extra dimension of some of the things that might be curative, so maybe there's a surgery, I've been found to have some sort of let's say a tumor or something else that is slow growing, for example, and to weigh if I have to have surgery, especially now in the time of COVID, what is the physical toll that's going to be taken on me through this thing that's supposed to cure me? The after effects of the anesthesia. Am I going to be able to physically endure surgery and recover? The body heals not so quickly or well anymore as it used to be. My immune system is not what it was. So some of the things that used to be like I'm not saying a no-brainer, but it's like, yeah, okay, let's do the surgery. When you're with someone who's living with dementia, especially reaching towards the end stage, I'm not saying no, but I would say pause and try and step back and look at the whole person and the whole quality of life for what you can estimate is the remaining time. Medications are amazing. And those start to not work so well sometimes for people with dementia. So I get if you and I get a UTI, a urinary tract infection, and we get the correct antibiotic and we kick the urinary tract infection, that's it generally. For people who are living with dementia and their immune system and older people in general, but people living with dementia in particular, the immune system is compromised. Those UTIs keep coming back and they keep coming back, and we keep giving stronger and stronger antibiotics, which leads to issues with gut, killing all the other good flora and fauna, which leads to diarrhea. So it can be a snowballing effect, which might lead to dehydration. So it's like, whoa, let's pause. If we're starting to see that this is not achieving its goal of good as new and we're done, we fixed it, let's take a step back and see what the options are. Another one is restorative, and this one comes up a lot for people living with dementia after a fall, for example. So I have fallen and I break a hip, and maybe I had some surgery, or maybe I didn't need surgery for it, depending on the kind of break. Whoops, sorry. And I go to rehab. So the focus of the restorative care is to help me regain some skills. So I had a drop in ability, and now through this restorative thing, so I go to rehab, I have special equipment, now I have a walker, they teach me how to use the walker, they try to teach me how to stand and sit. I might not get back to the full level where I was walking without a walker, but I'm better than I was when I fell down and went to the hospital. So that's the goal, not perfect, but back to a higher level of function. So there's a lot of challenges that we find ourselves as care partners and for people living with dementia in rehab because of a number of things. the environment, just like a hospital environment, can be very disorienting, and they might have trouble with agitation or delusions and things like that in a different kind of environment. Not always, but also they might not want to. I've heard this a lot of times. Refuses to participate. So I have no memory of my fall. I don't need that. Just leave me alone. I'm not going to do it. You can't make me do it. And it can be so frustrating because you just like, Dad, if you just go with the physical therapist, just no, nope. so that's a special challenge. And the other is to remember I'm living with dementia, and my short-term memory is likely severely impaired, and you're asking me to learn something new. And in the moment, I might be okay. Yes, I'll use this walker now, and this physical therapist is very nice, and I'm doing well. But a few minutes later, I'm going to get up and try and walk without my walker because I can't hold on to that. I have trouble learning these new things. And a lot of the techniques in restorative care are very detailed. Even something like, okay, now, because you've had this fall, you want to make sure every time you stand up, make sure you go to the edge of your chair, make sure your backside is at the edge of the chair, your feet are flat on the ground, okay, and then you're going to have to lean forward first. Don't just stand up. Whoa, that's a lot of steps. Again, learning a new skill, multi-step new skill, it's often impossible for me, a person living with dementia. And it doesn't mean I'm not trying or that I don't care. It's because of the changes in my brain. And so this level of care can be a challenge as well. Sometimes it does help and sometimes it doesn't, but it's just something to really look at when you're going through this. So the next one is the maintenance. So these are not completely separate. Sometimes you might be doing rehab while you're doing maintenance. But the goal of this, the previous goals were, regain full function, fix it, get better. At this point, we're recognizing like, okay, we're not getting better, but we don't want to get worse. So let's see if we can just keep the status quo. Don't, so if I can control, okay, if I put his walker right in front of him, and I make sure I have the handrails here, and and he really likes this caregiver, I'll get the same one every day. It depends on things not changing, because when I'm living with dementia, the more things are the same, the better I'm able to move from A to B and be a little less confused at times. But I'm going to put us all on pause. Whatever stays the same in life, not just with dementia. The person who's living with dementia is changing, so things that did work will start not to work so well because my dementia is progressing. Even if you are the 24/7 caregiver, you're not, well, let me back up a little bit. No one person can be the 24/7 caregiver of someone living with dementia without burning out. It takes a huge toll on your body and your mind and your heart. So you build a team and you have a number of caregivers, but not everybody can be there all the time. Things happen, people get sick, people need a break. So you can't have 100% caregiver consistency. And even if I'm the consistent caregiver, I'm not the same every day either. And look now during a pandemic, kind of very stressful times, I have my ups and downs, and I'm not the same all the time either. So we're struggling so hard to hang on and keep the status quo. If I can just keep this, and we do try and have consistency here at Halikwiki, for example. We have assigned seats for meals, so things seem to be more the same, and just kind of, but to recognize that you cannot control everything, and that you can try and make a consistency, but things will change. Things will change, and we're going to be figuring out what to do when we start seeing those changes. So the next one is compensatory. So we recognize there are things that they just can't do anymore, and we're going to have to do it for them basically, or do it with them. So we make supportive changes. So I have a picture here of a shower chair, for example. So I'm not able to step in and out of the shower. I got to use the shower transfer chair, and I have to make sure that the soap and all those things are laid out exactly so. And then I'm going to be, next to them, and then we're going to make a schedule. We're still trying to keep the status quo, but we're recognizing that we need to make a lot of adjustments here. And this is where a lot of we're compensating for what they've lost. So skills, specifically skills they've lost. So my mobility is changing. So now you have to not just use the walker, but someone has to be there holding on to me. I'm having trouble eating. We'll be doing more on this in the dining, but I may be at the point where you need to help me eat. You're help spooning food into my mouth for me. So you're compensating for my loss. And then this last one, palliative care and comfort care. This level of care is where you can do this with me, letting go of fixing and moving on to comforting. And by when I say letting go for fixing, I don't mean it like, oh, do nothing, just we let go of those fixes and that we now recognize are not going to be able to fix them. This surgery is not going to fix this. This medication is not going to fix it anymore. So we're going to focus on quality of life, comfort and quality of life. And this is where Hope's session next week, Tuesday, will be. I'm so excited to have the full session on this topic because it's so important to have this conversation early. And so those of you who are on this webinar, think of yourselves, and Hope will be asking you to think about this too, about what your preferences are if you don't have advanced care directives yet. And also for the person that you're caring for, do they have advanced care directives? Probably do. Taking a good look at it, and if the person is still able to be part of that conversation, that is great. If they aren't, this document is there for you to look to when we get to those hard points in life down the road when we have to make this care decisions for them. So comfort care, managing the pain, managing distress, anxiety, fear, discomfort. So we want to meet their needs of who they are in this moment, who they are as they're reaching the end of the life. So some things might have changed, things I might have wanted, interventions I might have wanted when I was more able-bodied might have changed now that I'm getting closer to the end. So the thing is acute illness versus dementia. So those types of approaches to care that involve fixing and repairing and getting better generally are in the acute illness side. So you can fix it, it gets better or goes away. The amount of time it lasts is finite. There are things doctors know that can do to make it better, and you go back to how you were pre-illness. On the flip side with dementia, you can't change it. So it's a progressive disease, and many of the healthcare problems that come up as you reach towards the end of life are directly related to the dementia. So repeated UTIs, repeated pneumonia. It sounds like something that's happening externally, but it's because of the brain changes and the compromised immune system, and it just keeps getting worse no matter how many antibiotics you throw at it, for example. And this dementia lasts a long time, like I said, years, and there's things that can help. There are things that can help, but there isn't a fix. And the person and their abilities will not be the same again. You can't go back, but you can be there with them in the moment, in this moment today, and in the moments all the way through the end of life. So we're going to look at what it is to let go versus giving up. How do we know when it's time? How will you know what's going to be enough? Did I do enough? Did I make the right choices? Who's going to be, so looking around you, who's going to be with you as you make these kinds of decisions? And how do you balance old wishes and promises that you might have made with the current realities. So it's it can be something as which I've seen personally, where someone might say, and this is not medical care, but may make sure you always pluck out all my my whiskers. I don't want to look like Aunt Ellen over there all the time with a old lady with a mustache, right? I might have said that to you, but now when you come and try and pluck those out, would be screaming bloody murder and think you're trying. No, you're hurting me. It's like, wait, but I promised you that I would always do that. But now I'm pushing back from you. It's like, whoa, whoa, whoa. The current reality for me is I can't tolerate it. So that's just a small example. And then what are our choices? What can we do? What can we do instead? Whoops, sorry. We want to look at when we make the decisions for medical decisions or the type of care decisions, we want to look at, and when I say cost, I don't necessarily mean money, the physical and emotional cost versus benefit to the person. So an extra physical and emotional cost these days, with making choices to go to hospitals or to go in for certain kinds of procedures for people living with dementia. This is something that our residents and our families are facing here at Halikwike, is to go anywhere, you have to have the COVID test, right? You go stay in a hospital for a while, then you're gonna have to have another one coming back. So there's that invasive, very scary, quick but scary procedure. And then there's the quarantining that happens, both in rehab settings and hospital settings, and often returning to long-term care settings like Halikwike. You might have in-room quarantine, which is it's a cost. It's a price that has to be paid in order to make the things happen safely. But that wasn't there before before the pandemic. What's possible versus what's probable. So this is where often you might have a conflict, not conflict, but a different perspective between a specialist and your geriatrician. So specialists are fantastic, and they can see what is possible. If I just do this surgery on your 95-year-old mother, it'll be quick, it'll be anesthesia, we'll just send her straight back home right after. It's like, whoa, whoa, whoa. They might not be looking at the whole picture of what it's going to be like for the person, what the physical price will be paid, how disoriented they'll be, what's the increased risk of falling when they come home, are they going to, so anyway, so looking at what the probable outcome is for the person at this stage, and then seeing what is the best case outcome, and is it really worth it, and so again, looking at what they tell you before, and is this about, and this is a really hard one, especially for our own families. And I know I face this, our family faced this as well with the question of a feeding tube, for example. Is this for the person, or is this because we're hanging on to the person we don't want? And we'll go into feeding tubes a little bit later, but is this about us, or is it really about them? And we're in this together, but it's hard to make those decisions that or feel might not prolong their life necessarily. But when you're balancing it out with the life prolonging option, really reduces their quality of life. So that's the balance. There's the balance that we're looking at. And that's why palliative care is making the choice that we're going to put the emphasis on quality of life. So I want to take a quick look at brains. Some of you, I don't know if you can see behind me, I have my special brain mug, my brain anatomy mug. It's all about the brain and the brain changes, because the diseases that cause dementia are degenerative brain diseases. So this one is Alzheimer's in particular, and you can see the PET scan on the left. The red is the all cylinders firing. I don't know if it's not really hot, but it looks like it's hot because it's red. And then all the way down to the dark blue, purple centers, those are pockets of fluid without brain activity, and that's perfectly normal. And then you can see the slices. So it's sliced kind of like this. This is the front right here, frontal lobe. This is the back. occipital lobe, early Alzheimer's, and then late Alzheimer's. This is an 18-month-old child here. But you can see there's a lot of change in brain activity as it progresses. So this early Alzheimer's brain here, when I use this slide with our staff, I tell them, these people are not living here at Haliquike. They're likely still at home. They may still be driving. They're having challenges, certainly, and making mistakes. But they might not be here yet. So we get people here a little further along, not a lot, but a little further along, all the way through end stage, through hospice care here at Haliquike. But while you see a lot of loss, so comparing the red and the purple from beginning to end, and it's easy to focus on what's lost because there is so much lost. But let's shift a little bit and look at what remains. They're still there. They are different, but they are who they were. They always were, and they always are. And so these brain activity, this is the primitive brain here, is still operating. And if you look at the 18-month-old child, very similar, right? And so we're not born fully developed, right? We grow into this mature brain. It takes a long time. It takes a long time to develop, even teens and early 20s, it's still developing. So just a quick question here. The top row and the bottom row, it's the same brain. So so it's like two different depth slices. It's the same brain. So it's like this. Yeah, a little different depth there. It's a good question. Okay, so I'm going to go forward and we'll just take a look at the physical brain. So that was the brain activity you were looking at. So this is the health. So these individuals very generously donated their brains after death for us to learn from. And then this is the healthy brain, someone who died without any Alzheimer's disease. And this is someone who passed away from Alzheimer's disease. So the actual brain is shrinking and cells are dying. And so there's actually holes inside as well. So you saw that there were pockets and pockets of more and more purple and dark blue. And this is the physical reason. So the cells are shrinking and dying, and consequently the chemical production is going down too. So that's so where is this journey going? So this is the GEMS model, which I mentioned at the beginning, where we look at, instead of looking at the person and with labels of early, middle, late, mild, moderate, severe, or stick in a number, 1, 2, 3, 4, 5, 1 to 6. Those models, they're important, and they do correspond to this GEMS model as well. They focus pretty exclusively on what's lost. So now, at stage 1, you can't do this. Stage 2, you can't do that. So we want to understand what's lost, but we want to understand what's still there also, because a lot does remain, and we want to know how to meet them where they are. What are their needs in those moments? So when I get a call from someone who says, I just saw my mother's geriatrician and they said she has, she's a 3. I'm like, I'm not sure exactly what that means. There are different scales and different numbers, and that it doesn't really tell me who she is or the full picture. So this GEM state is a way for us to look at those changes and not judge one as better than the other. The other systems have a lot of judgment kind of folded into it, which because we always want to be number one, what we call the best one, because it's the least dementia, and nobody wants to be the 7 because that one is they call it profound dementia. So it's very negative labels, but the gem, when we look at them as gems, each person is a unique, beautiful gem that needs a unique setting and care to shine. I'm shining up my gems here. So we are, and all of our brains are in this together. We are the sapphires, the true blue stones that are, we as we age, our brains slow down a little. If you're older, and you might have noticed, I know I'm noticing it, things just take a little longer to find that name, or it's like, wait, why did I come in this room? Things like that, perfectly normal. sapphires are the gems that support all the other gems. So as the diamonds, emeralds, ambers, rubies, and pearls, people living with dementia are moving through their lives and their journey of life, um, we're the ones that can support them. So the earlier stages, the diamonds, where I can be shining and have a lot of facets, but I might repeat things a lot. I become fixated on things. I need routine, and I might be cutting. I might kind of be rude sometimes. You think, or what I might get labeled as stubborn, but things have to be a certain way for me, and it's because that's how I can move through life and feel in control. Emeralds, green means go, so green, yellow, red, this is the stoplight sequence. I'm on the go. I'm not sure where or when. I might be time traveling in a sense. I'm 85 and I'm waiting for my mother to come pick me up, which was the case with my grandmother. She was always waiting for her parents. Um, but we're going to look at these last three gems more closely today. So the ambers, so amber is a stone that's formed by sap that falls from a tree and then fossilizes. So you remember in Jurassic Park, catches the mosquito, it's a moment in time. I'm stuck in the moment in time. I'm all about the now and I'm all about the sensations. If it feels good, I'll keep doing it. If it doesn't feel good to me, I'm not going to tolerate it. So I have a high sensory need, but low sensory tolerance. You might imagine that makes personal care really hard. So our high sensory areas are nose, mouth, everywhere where your oxygen mask would go, fingertips, tips of your toes, genitals. Where do we do all our personal care for people when people can't? Toothbrushing, nail clipping, toileting. It can become a real challenge. Rubies, red means stop. So this is the stage where I start to lose. Um, um, uh, I have trouble getting started from a stop, and when I'm going, I have trouble stopping. So that's what the stop and go means. I'm all about gross motor. My fine motor skills are starting to go away. I might be grabbing things with my hand this way more rather than with these three fingers, for example. I can go forward. I have trouble going backwards. Things are really starting to stop and slow down. The last one, the pearl. If you make your hands like this and picture an oyster shell. So if you look at your oyster shell on the outside, um, your first thought might be like, oh, that's delicious. I love oysters. But anyway, if you look at the oyster shell, what's it look like? It's rough, it's jagged, it's sharp. If you try and open it, you can cut your fingers if you're not careful. And it stays firmly clamped shut. It does not want to open. But hidden away, if you open it just right, if you can peek in there, there's that pearl hidden in there, hidden in the shell. If you looked on the outside, you would never imagine that there's something so beautiful and precious that took a long time to make in there. And that the end of life stages of dementia is a lot like that. They become very contracted, physically contracted, and shut down a lot. It's hard to find the person in there when you're looking at the shell, the human body shell, which can also be very rough and a lot of weight loss, kind of more bony looking. It can be hard to look at sometimes. Let's see here. Okay, so indications that you're getting near the end: ambers, rubies, and pearls. So these are some of the signs that you might start to see in those later stages. And I mentioned a number of times because it's so common, is the repeated infections. Antibiotics don't seem to work like they used to anymore. Refusal to eat, even favorite things. So I'll go into it more in the dining workshop. But things are changing with the way they eat. So I might be putting food in my mouth and I'm just pocketing it all, and my brain's not able to make the next step to swallow it properly. And when I do, I might swallow it incorrectly. I might aspirate it. So I'm having trouble. We do it unconsciously, of course, like breathe and then eat. Don't breathe your food, right? But that system starts to not work so well anymore. So I might aspirate my food, even my own saliva. I might constantly be like, what? Are you sick? Do you know? but no, it's I'm having trouble with that system. You might notice I sleep a lot more. I if you any moments pause and I'm asleep, and I might not be up very many hours of the day at all anymore. This is a change, a change. This is different than I sleep all day and then I'm up all night, which can happen at other, reversing your days and nights. That's a different thing. I just start to everything is slowing down. Um, you may even notice this one up top here, withdrawal from the world around, closing the eyes. So maybe I'm not asleep, but I sit with my eyes shut a lot. I might even eat with my eyes shut. I've known many people who are living with dementia who do that. Whether, they might look down to get their food, but when they put the food in, or if they're being assisted eating, if they're being fed, their eyes are closed the whole time. The sensory input of the world, which we take for granted in some ways, it's just too much. And I'm just going to focus. I'm going to shut that part out, and I'm just going to focus on eating, for example, or just the other things. Primitive reflexes show up. So you might see things like, of course, I mentioned the contractures. I might startle more easily. If you touch me here, I might do that infant rooting reflex. When I do talk, I might talk about, and many people have, and I'm sure Hopal mentioned it as well, as you reach into your life, talk about going home, talking about seeing people maybe they haven't, who have passed away, who are waiting for them, things like that. Wounds not healing, that's another one as well. Your skin gets very, very thin, and you're just, because I'm not able to, well, sometimes it's you're not able to eat, but even sometimes people, they're able to eat and they're eating all the time, but they're still losing weight. So it's like, I don't understand how mom's losing all this weight. She eats like a horse. Well, I'm eating it, but my body can't process it and absorb it. It's just going right through. So I just can't keep the weight on. So, and then if you can't absorb nutrients, your body doesn't have what it needs to heal wounds either. And that comes up again when you're thinking about doing interventions that involve things like surgery. Are they going to be able to heal in that way? Communication might change. I might be more, as I might lose language, and especially as I start to close up, I might have more moaning, might have more kind of self-stimulation kind of sounds, sucking, lip smacking, things like that. It's just I'm busy. It's something that I'm doing it by myself, doing myself. So I'm going to go forward here. So what does this mean for us when we start seeing these things? If there are some things, like, for example, I've had a resident who has had frequent testing for a certain, let's say it's kidney disease or cancer, and that means going in for appointments or having biopsies or doing it. If there is not a treatment that would be pursued, so, maybe we don't have to do all those testing anymore, for example. A simple one like mammograms. I'm not sure what the recommended age is now to stop doing mammograms, but I've had residents who are in their 80s and still getting mammograms. Well, at this point, would you really consider, if there was breast cancer, doing any kind of aggressive therapies? Maybe not. If not, then can we dial back the invasive or the uncomfortable monitoring that we would have done when you were younger, which would have been provide what the person wants or needs. I will probably not tolerate a mammogram for one when I'm 80 something and have dementia. And what can we do to provide comfort? And this last one, this giving permission, that is a big one. A lot of times the people that we're caring for, it might be a spouse, it might be a parent. They love us and they want to know that we'll be okay. And so giving them permission and reassurance that you will be okay. is a really big thing. So what does this mean? So this kind of goes this way. So don't treat infections if if it's not gonna uh, be able to result in a good fix. You can treat the discomfort of the infections. So, for example, with the UTIs, I've known many people who the consequence of the higher and higher antibiotics, the price was too high to pay, um, and it they moved to treating the discomfort if there is. Sometimes there isn't. They have a UTI, but then sometimes there isn't. Not forcing the intake meaning food, offering and accepting when it's not wanted. That's a really hard one. We'll go deeper into that in the dining one. So not pushing fluids. There's things things can be thickened if there's aspiration. Being careful not to force movements and just be doing things to the shell. Remember that oyster shell? Because if you take your hands, for example, and contract them like this and pull them close into your body, so as you reach the end, this contracture, my brain is able to fire and turn my muscles on. So go ahead and do it but it can't unrelax. It can't relax them. They're just on like this. So if you want to clean under my armpit, a very common way of doing it would be to try and pull me out this way. But that's going against what my muscles are doing. Don't force an interaction. There's other ways you can come in from the backside there. To 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 use touch, massage, controlled repositioning because of that physical change. So a lot, and then the big one, whoops. Oh, sorry. Here we go. Being present. And and this can be hard sometimes, is sitting in silence or with music and just space to be present and seeing what they're showing you and telling you, even if they don't have words. Um, you can, I mentioned all of these already, but being present and holding hands, hand under hand like this. Take your one hand, this is your hand. Your other hand is the person that you love and they're caring for, and press palm to palm like this. Palm to palm pressure. Palm to palm pressure. Here's a picture of it. Very comforting. If you're feeling stressed, doing this, you might see people do it on, the term wringing your hands. It's self-soothing. That's what that is when you do that. It's like a little hand massage. This is hardwired in us. It makes us feel better. So connecting this way and being there, and the top skin is so thin, if you're not holding on the top, if you're touching on the bottom, you're less likely to have skin tears as well. So in this photo, her hand is gently here, but the bottom hand can give that input, that comforting presence. So at the very end, I'm the pearl. I'm hidden in my shell. I'm still and quiet, but I'm beautiful. I was formed for many layers. I can be hard to move and hard to connect to, but I'm still there. And that it's a sign that the end of the journey is near. They often need our permission to go. And we're often the bridge, the connection. And so the connections at that time are a lot more physical and sensory. So the sounds in the room, smells, I can still hearing is all the way through the very end. I know for my grandmother, when she was at home under hospice care at the very end, we could be in there with her, and if you squeezed her hand, she would squeeze back, even though there weren't any words coming at that moment. But she could hear us, and then we could tell her how much we loved her, that we were going to be okay. I'm going to make myself tear up. She could go and see Grandpa again. But on this one, we talked about a lot of these already. Knows familiar and unfamiliar still. It really is true. So even though they might be able to say your name, if you can make that connection and their eyes open for that moment and they see you and you can see that you have that moment in time. It's true, it's real. And uh, they they know you as someone who loves them. In my grandmother's case, her her sister. So my grandmother. Sometimes I show a picture of her in these webinars, but I didn't put one in today. But she and her sister came over from Japan right before World War II, and they didn't get to see each other a lot, even though they both lived on Oahu, and my grandmother lived in Hauula, and my aunt lived in town. But right close to the end of my grandmother's life, when she was in that stage I was telling you about, when she wasn't talking much, when my aunt came out, my cousin brought her out, and she went into the bedroom and held my grandmother's hand and talked to her in Japanese. And my grandmother opened her eyes and was speaking in Japanese. I only took 2 years in high school. I can't remember. I was terrible. Anyway, uh, but she recognized 100% recognized that voice of her sister. Whether she was saying whether what she was saying was intelligible, I don't know, but it it made that big difference. And she passed away within a couple days after that visit. But she was there. She she was who she always was, but physically different. And so that's the memory that I'll always treasure, and a wonderful lesson that she taught me about the full journey of life. So we're going to look at like what at this very end stage, what can they still do? What can things can we do with them? So we're looking at for familiar sounds and voices, for warmth, physical comfort and warmth, soft textures, pleasant smells. I might not be eating anymore at all, but I might still taste things. For me, it would be chocolate. Maybe I can't swallow anymore, but I can taste it. I knew one family who would put a little dab of like whiskey for their dad, for their dad, just to fill your senses that way. Slow, smooth movement. So we did this palm under palm to yourself, right? If you have someone in your bubble with you, you can do it to each other. But the other thing is take your palms and flats of your fingers and put that on your joint, like your shoulder, put that nice weight there on your elbow, maybe on your knee. And if you can rub with the palm and flat fingers, as opposed to like squeezing, slow, broad movements, that feels really good. Across the back, I can't quite do it to myself, but it feels really good, not just for people with dementia, everyone. So it can take a little while to get started. They start to lose trunk control, so it's hard to stay upright. You might have to prop with pillows. Um, uh, oh, here. So these are some of the care issues. We talked about these a little earlier. The weight loss, the skin changes, the language changes. So you want to make sure when because you can connect visually, but you need to get into a position, and this kind of camera is very similar to it. You want to be where they can see you. If you're off to the side and their line of vision is going this way, it's going to be hard for them to be able to focus on you, right? And you want the light, like you might have seen in people's Zoom setups, have light shining this way so that my face is lit up so it's easier for you to see me. Same in the room. So if the light is behind you, your face will be black and it'll be hard to see. Bring lights up carefully, right, as opposed to flipping them on. So everything is slowed down. Move slowly, speak slowly, raise the volumes or the lights slowly so they have a chance to get used to it, because their processing speed is slower. It's going to take me a little while to clue in. Keeping your voice deep and calm. So as we age, we start to lose our higher registers. I don't know if you remember, there used to be this ringtone that only young people could hear. But low and slow. Keep your voice low and slow. And things that are rhythmic, I can connect to better. So the part of the brain that has music, poetry, prayer, all those rhythmic things. You know, sing to me songs from my youth. Tell me what you're doing and what's happening while you're giving the care. Um, uh, Reflect emotions you think you see in my face. You know, offer and not being positive, offering positive comments and care, and then uh, being quiet sometimes. You know, so sometimes we have a lot to say, but also giving them that space for the quiet to be there with them. We already went over this about the firm and gentle um, pressure. This one here, the once physically connected, keep it. So if I come in and have my physical connection here, and I've got your attention, try and keep that connection. You could use your other hand to help if you're doing your hair or putting on glasses or things like that. But keeping that connection, whether it's a hand on the shoulder or hand under hand here. And then this hand under hand while doing something intense. That something intense is it could be a number of things, but often it's touching those high sensory areas. And which were those again? Here, fingertips, genitals, toes, right? So if you want to help me brush my teeth, you can get over my mouth and do it for me, and it will feel like you could get somebody to do this to you so you can see what it's like, especially if your eyes are closed. It's very alarming. Or you can still hold the toothbrush and get into that hand in her hand so that their arm is moving with you. That's what they're saying. So my brain has brushed my teeth a million times, and even though I'm not controlling the toothbrush, you are, it feels like to my brain that I am. So that's an intense thing that I still might not be happy about it, but it won't be the same as someone coming at me with a toothbrush without me. So do things with me, even though I'm at the end, as much as you can with me. And if there are no words, and there's very often there aren't, if someone has gone all the way through to the pearl stage, they are still communicating. So even without words, that young child, that 18-month-old brain that you saw, they communicate a lot with very, very little and no words sometimes. What are they showing you with their face, with their sounds, their movements? You know, if you ask them how they're in pain, they might not be able to tell you, most likely, but you might see it in their face. You might see it in the extra contraction. You might see it in teeth gritting, you know. And then making your cues bigger and simpler and slower. So we rely on words a lot, words and movements together, visual cues and verbal cues together, or even a touch cue with the hand under hand. Keeping it slow, keep it simple and keep it slow. So I want to have us take a look at a pearl. And so this is Teepa Snow. So the care approach, the positive approach to care, is a organization, a movement developed by Teepa Snow, who's an occupational therapist on the mainland. And so that's the training system that I was trained in, and the training system we use here at Hale Ku'ike. But this is her giving a presentation about end of life, and this little video about her and this lady named Pearl, just by chance, who's towards the end of life. So what you'll see is Teepa with this lady Pearl, this one right here, and you also hear her because she's speaking at this conference. You'll hear her voiceover talking about the video. So you can hear her voice in the video itself, but also in talking about the video too. So we'll take a look here and see what kind of things that we notice about Pearl.
My friend Pearl, and I want you to watch her interaction with me. Pearl. No obvious reaction at all, is there? Pearl. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. Hey! It took her 6 seconds to realize I was there, from the call of her name until she found me. That's how long it took her brain to go from a sound, her name, oh, it's somebody calling me, they were over there, I should look. How often do we give people that much time to recognize that we're coming? Yeah. It's Teepa. I'm gonna help you get up and get washed up.
In my vision.
Okay.
She
All right,
connected?
I'm gonna put the rail down.
Yep. Notice I keep hold on her when I'm moving around so I don't lose her. I don't want the shell to close.
Let's take the cover and put the cover down.
Take a look at her legs.
Good. That's it.
She can't straighten them out. The muscles have drawn up. Take a look at her feet. They're purple. Circulation is failing.
Okay. All right. Now, first of all, I'm going to put on your socks. I'm going to put on your socks. Okay. Yeah, here we go. I'm going to turn the sock right side out.
Does she
Put it on.
comprehend my words? Not necessarily. Does she pick up on my tone of voice and know that I'm about to do something? And notice how I'm sliding my hand down her leg to get to the foot?
Foot.
Look
There
how
you go.
purple it is.
Good.
Poor circulation.
That's it.
Systems are shutting down. She won't heal
Alright.
a wound down there anymore.
Okay.
And I'll
Let's
bring the
put this
leg
leg
up
over.
and in.
There you go.
Up
And put it down.
and in.
Good job. All right. Good work. How's that? Yeah. Pearl, I have a washcloth for you. I'm going to help you wash your face off. I'm going to help you wash your face off. That's it. Let me see your hand here. Good. Now, here we go. I'm going to wash your face. It is one, isn't it? Let's do your cheeks.
Now, people think she's trying to eat the washcloth. It's a primitive birth reflex called a rooting reflex. I touched her cheek, she's turning to the nipple. Primitive reflexes reemerge. Is she connected to me? Yeah, this is a lady, she was a public health nurse for 50 years. She's within 5 days of dying. And yet, she's right there. We have a moment to connect because I accept she is where she is, and yet she's very aware of me in this moment. My friend.
Yeah, I love that lady Pearl, and so you could see how Teepa stayed connected, and that one thing that she does in the very beginning, that she counted out loud for the audience there from when she said Pearl, and then counted 1,000 all the way till 6 before she turned. I do that in my head sometimes to make myself slow down because our brains are going 100 miles an hour, and silence is hard for us as human beings, like waiting for someone to say something. So sometimes I will use that technique for myself. So I'll call somebody's name or ask a question, and to force myself to wait, I'll count. And it also helps give me a little bit of feedback. It's like, oh, okay, this person, turned and responded in 3 seconds, where this other resident or other person I know, took 8 seconds, or, after 10, they didn't respond at all. I need to do another approach, maybe stand in a different place. But it gives that opportunity and chance and respect to that person to give them, let them respond in their own time if they are able. Yeah. So I wanted to just do a quick review here about the true false questions that you answered in the beginning, and this is a little review of what we've covered today. So the first one is definitely true. In the late stages, primitive reflexes and muscle contractures are prevalent, and you saw in the lady Pearl where her legs were continually drawn up like that. She can't unrelax them. Yeah, it used to be in the old days when people had contractures, they would like split them open like a hand contractor, but now that we don't do that anymore. So pneumonia, dehydration, sepsis are common causes of death for late stage. Yes, 100%. So all related to the dementia, the vulnerability to these at the end of a life. So that one is true. So this is the key in this question is that late stage, a successful routine of activities in late stages, keep them awake as much as possible of the day to encourage nighttime sleep. In the late stage, trying to keep me awake when my brain just can't take in that much data anymore will more likely lead to me being, well, cranky for one, or just a lack of success and the constant headbutting, we're trying to wake that person up. Sleeping more is just a part of my journey there. So in earlier stages, and I mentioned earlier in the webinar about people having their nights and days reversed. Yeah, having things to do during the day so that they're not napping all the time and awake all night, that's a different question. So this one is false. For late stage dementia, keeping someone awake as much as possible is not the best strategy. A person in late stage can make eye contact and respond to palm, 100% true. They really, 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 really can. And then allowing them to be up for shorter periods and rest longer and focusing on pain management are examples of comfort care. Yes, that is true, 100% true. I want to make sure we have enough time for questions. I'm going to flip to the next slide here, and we do have, as mentioned earlier, a follow-up webinar to this one. So all the things that we explored in this journey all the way to Pearl, the different kinds of care, the signs, and what it's like at the end. The November 10th webinar, you want to take a step back and do a little more planning for maybe yourself, or if you have someone who's in the earlier stages of dementia, but also looking if someone's already in these later stages, how do we go back and look at what advanced care planning is already done, and to honor their wishes and see if comfort care is what they would wanted at that stage or not. It's a very individual decision. We also have another webinar on dining with dementia on next week, Thursday, at the same 10 o'clock time. So I'm going to, before I move on to the question and answer, I'm going to put that poll up again. This is the post test, so it's the same questions. So if you didn't get to take it the first time, that's okay, you can still take it now. So, but it really does help our grants. I'll put this up, and please go ahead and answer those questions there. And I am going to I want to thank everyone for coming. You can learn more about the Catholic Charities Circle of Care at catholiccharities.hawaii.org //dementia, Halikwike at halikwike.com. And if you want to know more about positive approach to care, and it would be tipasnow.com. So I'm going to actually take this screen down. I'm going to stop sharing, and it'll just be me on the screen. And then I'm going to go ahead and start answering questions. Okay, here we go. Jody, is there anything you wanted to add before I head into the question and answer?
Just that, thank you so much, Dorothy. That was wonderful. You could mention about the evaluation at the end. When we leave today, we have a eval that'll pop up, a survey. I know some of you might be leaving early or have left or something. We'll send a link. But if you could fill it out, that's great. It really helps the data for our grant. With federal grants, they want data. And the reason for that is they go to Congress and they try to get more money for Alzheimer's to give to the states. And in order to do that, they have to come with all the data that's been done and all the work that's been done. So that's why we ask you guys to do this. It's anonymous. That's important. You won't be, no one will know who you are when you do the survey. So I guess we can move on to the Q&A.
Yeah, I'll just take them in order, if that's okay. So the first one is, as cognitive decline increases, how do you determine the palliative needs, preferences, choices of the person living with dementia? The verbal responses diminish, so it's difficult to know. That is true. There becomes, you can't ask them anymore at a certain point. I would say the first thing to do is to, well, there's a few things. One is, did they have an advance directive already. Did they already have that document or conversation in the past? So that'd be something to look to. Talking to, especially as you're reaching towards the end, if you have hospice or palliative care on board, speaking with the physician, and getting to know what the nonverbal signals are. So towards the end of life, being able to say, I think this person's in pain, and having pain medications already ready on hand, and not waiting till to have to go get a prescription, because we want to, managing pain is one of the priorities under um, comfort care towards the end of life. So yeah, so it relies a lot on the nonverbal responses and kind of ruling things out, much like when you're trying to figure out uh, what's going on with a young child who's not verbal either. It's like, oh, are they hungry? Are they constipated? Are they, do they have a fever? So there's a lot of that kind of detective work that would be need to be done. I already answered the PET scan one about what top and row. What's cutting and diamonds mean? Oh, good question, because on that slide it said diamonds are cutting. So each of the gems that is chosen to represent the different levels, there's qualities about the actual gemstone that correspond to the state of dementia, or that place in the journey. So with diamonds, the stone are extremely hard and used for cutting in industry. Diamonds cut glass, things like that. So cutting in human beings is making a cutting remark, or being like rude, and then they're just kind of I can really bite you if you don't do things the way I think. And I don't mean physically bite you, but verbally bite you when you don't do things the way I think you should be doing them. Or you're sitting in my chair and I sit here. I pay good money to be here. What's this lady doing? So I it's like, whoa, calm down. I'm not going to calm down. So that's what I mean by cutting. So verbally cutting. And so I might get labeled as mean, mean, stubborn, things like that. Next question is, what is vascular dementia? So vascular dementia, your brain is a vascular organ, so it's a blood flow through your brain. Vascular dementia is dementia due to strokes. So blood is diminished or cut off to the brain, and you have a stroke, and then there's damage. So the damage to the brain to your blood vessels, or causes damage to your brain, and so that's called vascular dementia. So my father had vascular dementia because of TIA mini strokes that he had over time. So that changed how his brain worked. How do you learn the best types of massages? Well, that's a good question. I know there are massage therapists, and I know someone who teaches massage therapy at KCC and does a palliative care massage class for massage therapy students. That's a little bit different there. I don't know exactly where to learn the best types of massages. I'm sure I'm going to look more deeply into that. For non-professional massages, but just comfort touch, that palm to palm pressure, open palms, slow pressure, light pressure on the joints. Those are all comforting. That's, our brains are wired to like that type of thing. So even something like that, I wouldn't call it quite a massage, but comfort touch is using this part of the palm and going slowly. Let's see here, the next one. Any effective ideas for this stage for connecting by virtual means, FaceTime, Zoom, when touch is not possible because of COVID? Yes, that is. We here at Halikuike are on full lockdown since March 11th. It's been a very long 8 months that way. Our families have not been able to come in-person visits since then. And so FaceTime and Zoom is the way they've had to connect. So the physical touches our residents are getting are from us, the healthcare workers, but so I would say for connecting in the later stages through Zoom, the being able to have the person who can be there to be the touch, to be the hand under hand, to help maybe position the iPad or whatever it is so that you can be seen. And this is how we look at here. I have to be the family member's hands here. So when they're meeting, to have that reassuring touch. So that's one thing there. But what you can do from that side, so is having some of the tips the same as if you were there in person. Make sure you're well lit from the front so they can see your face on FaceTime. I'm sure you've all been on Zoom calls where the lighting was terrible on the person on the other end and you couldn't see their face very well, and it was kind of distracting and you couldn't hard to focus on what they're saying. So be well lit. Um, Try to have the noise minimum where you are so that there isn't a lot of background noise. Go to things that are rhythmic. If they're playing music, singing a song with them, even if you're not a very good singer. But one of my favorite things about people living with dementia is they're generally very forgiving audience. They might tell me I'm a terrible singer, but they give me a credit for trying. But yeah, children's songs, things from all the way up through their teen years. You can play recordings of it, sing along, poetry if they were a religious person. If there are prayers that they know, that's another kind of poetry. You might be surprised. Someone who's not speaking at all really might start to hum or mumble some of the words because it's a different part of the brain that's engaged, and that part of the brain remains all the way through the end. So that is one of the gifts that's left for us to connect with people towards the end there. Um, so next question is about, for a Pearl, would a loved pet help with comfort? Yes, it can. Yes, it can. So I would take the cue from the person. We have service dogs here at Halikwike that live full time. We have a cat at one of our locations, and so the we have had the dogs be in bed with someone at the end of their life, and that's something that they like and they can feel that they and we've had a cat who the cat loved to sleep with one of our residents as well. So yes, I would say yes. If that, and look to the person to see how they're reacting. Yes, Jody.
I just want to add something about the pet. I
Yeah.
cared for a lady who was in advanced dementia toward the end of her life, and somebody had given her a little Yorkie from the Humane Society, who was the devil in disguise as a dog. Beautiful dog, loved her, she loved the dog. But when she came to the end of her life and she had oxygen, the dog kept trying to pull the oxygen out.
Oh yeah.
So I would make sure there's a caregiver in the house, because also if the person is living alone or doesn't have somebody there 24/7, the dog might pee all over the place.
Yep.
The other situation is in later stages, of course, some people with dementia take their own meds, which is not advised maybe at the final stage. And she was dropping her meds on the floor and the dog was eating and ended up getting kidney disease from eating all of those. So I would be very careful that the caregiver keeps watch over that pet. It's not so much trouble with the cat, but especially jumping up on the bed. That little dog would, wander around, and here she was trying to sleep, and it would wake her up.
Yeah,
Sorry about that. I just wanted to.
Yep. No, it's good. It's good. It's not an automatic. And like anything, it takes monitoring and it's controlled. So I'll bring our little dog. Watch. It's not like, here's the dog, I'm going to go away. Generally,
we had to take the dog away and put it in the vet in the final days because he was disturbing her. And when she finally did pass, the hospice nurse told us, you need the dog to see her when she's passed, because the dog has to have closure. That's another thing we don't think about. And sure enough, we went and got the dog. I never knew this. And he put him on the bed. He sniffed and saw that she had passed. And that was it. He went off the bed, didn't go back. Apparently, pets also need to have closure.
We had our cat that we still have in Halikwike, when we had a resident move out. Actually, she didn't pass at Halikwike. She passed elsewhere. The cat grieved because you didn't have a chance to. You never think about cat grading, but they do. They do. So let me answer a few more questions. Good. One more time here. I think I lost my track of the order, but okay. Is it known if an individual with dementia is able to distinguish between different people, such as a caregiver, family member, or healthcare worker? I think they it it depends on the person, but I believe that they can know familiar and unfamiliar. Um, so here at Holly Kuike, for example, I'm a familiar face, but most residents don't remember exactly who I am. But there might be a couple of staff people that they do remember because they have a closer bond. Um, Family member, they might not recognize exactly who they are, but they know they're related somehow. So I might think my daughter is my wife or something like that. Man, someone, because she looks a lot like my wife did when she was younger or something like that. So yeah, they can tell different people, but they might not be able to put the facts together the way they used to. Yeah. Vascular dementia, is damage irrevocably permanent, or can time and treatment make recovery possible? Well, with strokes, there is damage to the brain, and there is there is like rehab and occupational therapy that can be done to help regain skills. Not necessarily all the way back up to the level that they were, but it can help, but it doesn't reverse the stroke or the brain damage. And that's why sometimes they'll do scans and they'll say, "Oh, it looks like you had a stroke 5 years ago." And you're like, "Oh, I didn't even know." So it's permanent. It's permanent. Um, do do you recommend using things like music therapy or aromatherapy? Yes, 100%. Those senses are still there. 100% music therapy, aromatherapy, and not just the end stage, any stage. Music is a powerful thing for our brains, and it transports us to another place and time. Okay, let's see. Um, what, let's see. What activities can we do to upkeep their cognitive skills? So, like for us, keeping engaged with meaningful engagement, and there are things that we can do now without living with dementia that can help keep up your cognitive skills. But when we're talking about dementia, dementia is not a normal part of aging. Dementia is caused by diseases. Something has gone wrong, and it's not just getting old. So Alzheimer's disease, Parkinson's disease, strokes, those are things that are causing the damage to my brain, and no amount of Sudoku is going to change that. But if I love Sudoku and I'm going to keep doing it, great, keep doing it. But staying socially connected, and doing things that make you feel like you're part, that you're useful, that I think we had a webinar, and there's a recording available about activities, and that can be really, really powerful for a good quality of life. Let's see. The one question was about the sessions recording. Yes, they are recorded, and Jody will send out information about or a post here where you can get the earlier sessions. Someone wrote, "I Zoom with my sister, and on one visit, she knew I lived on Kauai and mentioned it very proudly to her caregivers. But when they asked who I was talking to, she didn't have a clue. I helped her by telling her I'm her sister." Yes. So that's wonderful. Thank you so much for sharing that. When we know someone has cognitive impairment, let's help them out. So, hey, Mom, it's me, Dorothy, your daughter, Dorothy. So, don't make it a quiz show. Hey, do you know who I am? Which one am I? Nobody likes to be put on the spot or feels stupid. Of course, name tags help, saying who you are. These days, for all of us wearing masks out in public, I'm sure you must have had times where someone comes up to you and you're like, who is that? And then they start talking to you, or even without the masks. Sometimes it can be a little while before you recognize someone. Yeah, be kind, introduce yourself, even if it's every single time. And even if you wish in your heart of hearts that they would recognize you, it's not because they don't want to, they can't help it. It's because of the brain changes. So thank you for sharing that. And thank you for telling her. Yeah, that's great. Yeah. So it's not all or nothing. Like, I might remember you live on Kauai today, but I might not next time, or I might be able to get your name tomorrow, but not today. So here's a question about going to the bathroom. Yes, with the toileting question, my mom has begun to sit on the toilet a bit reclined rather than sitting up and forward, always with panties up over the knees. Yeah. So we underestimate how complicated little things are, how many steps it takes to go to the bathroom, from the moment we feel the urge to all the steps that it takes to step number one, hold your pee, to get all the way there, and then even all the steps that it takes to do all of that. So when you start noticing that I'm slipping with certain steps, that's a sign that things are changing in my brain, and that I would need your support. So I might need someone there to help me with my posture, or if that, especially because for a BM and things like that, it would be kind of hard to do it in that position. So yeah, the fine skill of pulling your underwear up and down, wiping, those start to slip. So when you start to see those happening, then that's where that supportive care comes in, when you'll have to replace the skill that they've lost. Yep, yep. We are at time right now, 11:30, and I want to be respectful of all of your time. I know there are some questions that I did not answer yet. I will write up the answers. Is that good, Jody? I'll write up the answers and send them to you.
Yeah, yes, thank you. That's great. There's one about music, and if music provides it, music as a non-pharmacological intervention. And we're going to be giving some more webinars coming up in November, starting on November 18th through December, with geriatricians. One of them is on non-pharmacological interventions, one of which is music. Yes, it is one of the ones that has proven to be beneficial, but it's very important to know what music the person likes. I'll let you all know when those webinars are for more detail about music. I just want to say that somebody mentioned about not accessing the link to the recordings. I send everybody a link to the website where all the recordings are. That person was anonymous. The question was anonymous. Every email that I sent recently and the next one will include the link where you can find the videos.
You can look for it in the next link. If you didn't notice it in the earlier emails, it'll be in the
That
next.
is correct. Yes.
Okay. Great. Anything else, Jody, before we wrap it up, other than please complete the survey.
Thank you again, Dorothy, for your moving and beautiful presentation. And thanks to the caregivers out there who are caring for a loved one, or as a professional caring for people with dementia. And we really honor all of you, and honor you, Dorothy, for the work you do.
Thank you. Thank you for putting this together. And thank you, everyone, for taking the time today. An hour and a half out of our schedules is a lot. It's a lot. So but you can give yourselves a little self-soothing massage as a gift to yourself. Think of something that you can do for yourself. Listen to a little music, smell something delicious, and take that moment for yourself. So, okay. Thank you very much, and thank you for all your questions. And I'll write it all up for those I didn't get to. I apologize for not being able to get to all of them. But see you again, hopefully next Tuesday or Thursday. Okay, bye.